So today I am going to explain regarding the anterior dislocation of the shoulder. So our last video was the complications of anterior dislocation of the shoulder, and we saw the neurological complication and vascular complication, and still we have the structural complication that I am going to explain once I finish the anterior dislocation of the shoulder. So coming to the instability of the shoulder. Shoulder instability can be broadly divided into three categories: the anterior dislocation, the posterior dislocation, as well as the inferior dislocation. Of these three dislocations, the anterior dislocation is the most common type of instability, and 95% of shoulder dislocation falls under anterior dislocations. Okay. And coming to the anterior dislocation can be classified mainly into four categories. That is, subcoracoid, when the head of the humerus falls just in front of the coracoid process. And the second one is preglenoid. It is also called as subglenoid. The third category of subclavicular, and the fourth category is intrathoracic. And intrathoracic is very rare case of anterior dislocation. Among these four types of anterior dislocation, subcoracoid is the most common type of anterior dislocation, which falls around 75% of the total cases of anterior dislocations. Okay, that are these are the subdivisions of anterior dislocation. Then we are coming to the mechanism of injury in case of anterior dislocation. What are the mechanism of injury in case of anterior dislocations? So anterior dislocation is caused by an abduction as well as an external rotation injury. Again, is caused by an abduction as well as an external rotation injury, and mainly the anterior dislocation occurs at 90 degrees of abduction and external rotation. Okay, anterior dislocation occurs at 90 degrees of abduction and external rotation. So when you analyze biomechanically, when you analyze the mechanism of injury, so when you are going for an external rotation of the shoulder, what is happening during an external rotation? During external rotation, the head of the humerus is moving anteriorly. The head of the humerus is moving anterior. That is the arthrokinematic movement during external rotation. Head of the humerus moving anteriorly, and during abduction, the head of the humerus is rolling inferiorly. This will cause the head of the humerus to move anteriorly and inferiorly during anterior dislocation. Next, let us see what are the etiology or what are the causative factors for anterior dislocation. So the causes for anterior dislocation can be divided into two subcategories. One is the traumatic cause and other one is the non-traumatic cause. When you take the traumatic cause, what is the traumatic cause? Fall on outstretched hand. Fall on the outstretched hand. So when a person fall on the outstretched hand, what is the position of the shoulder? The shoulder is going for an abduction and external rotation injury, which enhance the anterior dislocation. And second cause of traumatic case is of repeated overhead activities in sports. Repeated overhead activities in sports, especially these type of injuries can be seen in pitchers. What do you mean by pitcher? A pitcher is a player who throws the ball in a baseball game. So what is a baseball game? Baseball game is very similar to our cricket. It is a bat and ball game where a pitcher is also known as the player who throws the ball. A pitcher who throws the ball from the pitcher's mound to the catcher. Okay, so what happened when a pitcher throws the ball? So how he throws the ball? So he throws the ball like this. So there is a external rotation as well as abduction. So when these type of activities are repeating on a daily basis, this can cause stretch to the joint capsule as well as the structures that provide stability to the joint. Okay, and this syndrome we will see in detail once we come to the complications of anterior dislocation. So the pitcher's position is one of the causes. The pitcher's position is one of the causes for anterior instability in case of traumatic causes. And these pitcher's injury can also called as dead arm syndrome in pitchers. Dead arm syndrome in pitchers. Okay. So next, coming to the non-traumatic causes of anterior dislocations. So what are the non-traumatic causes? This can be caused mainly due to hereditary factors. Okay, the hereditary factors due to genetic malfunctioning or genetic malproportion, which contributes to the elasticity of the ligaments and joint capsule. So the non-traumatic causes can be mainly due to congenital causes. The congenital causes mainly due to hereditary, where there is a genetic disproportion which can result in the laxity of the ligaments and joint capsule. So when there is a laxity of the ligaments and joint capsule, the stability factor need to be compromised, which in turn can result in dislocations of the shoulder. Okay, so now let us see the clinical features, signs, as well as the various tests for anterior dislocation. So while coming to the clinical features, so when a shoulder is anteriorly dislocated, what is the position of the head of the humerus? So in an anteriorly dislocated shoulder, the head of the humerus can be seen anteriorly as well as inferiorly. So that is the position where the head of the humerus is seen. Why it is seen anteriorly and inferiorly? Because the mechanism of injury is abduction as well as an external rotation. So the arthrokinematic movement during abduction is the inferior rolling. So the head of the humerus moves inferiorly. And what is the arthrokinematic movement during external rotation? The head of the humerus moves anteriorly. So the head of the humerus moves anteriorly and inferiorly. The head of the humerus moves anteriorly and inferiorly, as well as the head of the humerus moves medially. So the head of the humerus moves inferiorly, anteriorly, as well as medially. Why the anterior position of the head of the humerus is, when you look into the orientation of the glenoid fossa is oriented superiorly as well as medially. So when the head of the humerus dislocate, the medially rotated, oriented position of the head of the humerus will enhance the medial movement of the head of the humerus. That's the reason why the head of the humerus is moving medially. Okay, so the head of the humerus can be seen anteriorly, inferiorly, and medially. And again, when you palpate the shoulder, when you palpate the suspected shoulder, you can see the head of the humerus can be felt anteriorly. The head of the humerus can be felt anteriorly in case of an anterior dislocated shoulder. And if you try to press on the shoulder, the patient will feel discomfort, or the patient will stop you from pressing the shoulder, and the patient will complain of pain. Okay, so the head of the humerus can be felt on the anterior aspect of the shoulder. Okay, and what will be the position of the shoulder in case of anterior dislocated shoulder? The shoulder will be in a slightly abducted as well as an external rotator position. The shoulder will be in the slightly abducted and external rotator position. Okay, if you ask the patient to bring the shoulder medially, the patient will not do the medial movement of the shoulder. So the shoulder is in the abducted as well as external rotator position in case of an anteriorly dislocated shoulder. Okay, and so what are the shoulder can be the head of the humerus can be seen anteriorly, medially, and inferiorly. And when you palpate the head of the humerus can be palpated anteriorly. The shoulder is in the abducted as well as the externally rotated position. And another important feature is that usually the acromion process in a normal person can be seen laterally as well as anteriorly. Okay, but in case of an anterior dislocated shoulder, the acromion process can be seen laterally and posteriorly. Why it is called posteriorly? Because when the head of the humerus is moving anteriorly, and when you look for the acromion process can be seen posterior to the head of the humerus. So in case of an anterior dislocated shoulder, the head of the humerus can be felt, the acromion process can be seen posteriorly as well as laterally, but when you are looking to the normal shoulder, the acromion process can be seen laterally as well as anteriorly. So a posterior dislocated shoulder, the acromion process is seen posteriorly as well as laterally, but in a normal shoulder, the acromion process can be seen anteriorly and laterally. Okay, and next we are looking into the neural complications. So what happened to the peripheral nerves, especially the axillary nerve, the nerve which prone to injury in case of anterior dislocation is the axillary nerve, because the axillary nerve winds around the surgical neck of the humerus, and when the head of the humerus moves anteriorly, it will cause a traction force on the axillary nerve, which can cause injury to the axillary nerve. And you can see the weakness of the deltoid muscle. The axillary nerve supplies the deltoid muscle as well as the teres minor. So there will be a weakness of the deltoid muscle. Okay, and you can see this disturbed sensation can be seen at the area of the deltoid. The disturbed sensation can be seen at the area of the deltoid. So this disturbed sensation is known as the regiment badge sign. Regiment badge sign. So that is called the regiment badge sign. Regiment badge sign. So what do you mean by the regiment badge sign? So when you look into the shoulder of a military officer, you can see a badge sticking exactly on the area of the deltoid in a military officer, which shows that which regiment that particular military officer belongs to. So that is called the regiment badge sign. So in case of anterior dislocation due to injury to axillary nerve, there is a sensory disturbance at the area of the deltoid, which can be represented as the regiment badge sign. Okay, decreased sensation along the deltoid muscle can be represented as the regiment badge sign. Okay, so that's about the neural complication. Then we are coming to the vascular complication. So in case of vascular complication, what is the artery or the blood vessel which can get injured in case of anterior dislocation is the axillary artery. And so as I told in my previous video, the axillary artery arises from the subclavian artery, and after crossing the teres major, it continues as the brachial artery. And this axial artery has got 6 branches. And the last video I forgot to explain the branches of the axillary artery. So the branches of the axillary artery can be remembered using a mnemonic: cystis, teens, love, sex and port. What do you mean by that? Cystis, yes, S stands for superior thoracic. And teens, cystis, teens, teen stands for thoracoacromial. So cystis, teens, love, L stands for lateral thoracic. Cystis, teens, love, sex means subscapular. Cystis, teens, love, sex, and A stands for anterior humeral circumflex artery. Port, P stands for posterior humeral circumflex artery. So these are the 6 branches of axillary artery. And when there is an anterior dislocation, there is a chances for the axillary artery to get injured. So what are the symptoms when you suspect of an arterial complication? So before going that, how will you differentiate an arterial complication as well as a venous complication? So there is a acronym or a mnemonic I developed. So in case of an arterial complication, just remember ACAP. ACAP. AC stands for air conditioner and AP. So imagine in case of arterial complications, arterial complication AC, arterial A stands for artery, C coldness of the skin will be cold in case of arterial complication, okay. And what is AP? Absent pulse. So in case of any arterial problems, you can see if you touch the skin of the patient, the skin is felt as cold, the coldness of the skin. And again you can see absent pulse in case of arterial complications. And when you look into the venous problems, okay, when you look into the venous problems, I formulated a mnemonic for venous complication, that is venous with blue sky. Venous with blue sky. So when you look for the venous complication, okay, when you look for the venous complication, think of this venous, VENUS. VENUS Venus is it's a planet, it is the hottest planet in the universe. So Venus with W stands for warm, and B, blue skies, B stands for bluish discoloration of the skin, and sky, S stands for swelling. So when you think about any venous complication, keep in your mind the Venus with blue sky, okay, that is Venus with, that is the warm, the skin will be warm, bluish coloration of the skin as well as the sky swelling. So but in case of arterial problems, there is the skin can be felt as cold and there is an absent pulse. So in case of arterial problem, axillary artery problems arises due to anterior dislocation, you can feel the coldness of the skin, you can see an absent pulse. And since I told about the branches of the axillary artery, I told there is a posterior humeral circumflex artery. And you might have heard that this axillary nerve is also called as the circumflex nerve. Why it is called as the circumflex nerve is that this axillary nerve, after crossing the neck of the surgical neck of the humerus, so this the axillary nerve moves from the surgical neck and it crosses anterior to the posterior, and after crossing the humerus and coming to the posterior aspect of the humerus, this axillary nerve goes along with the a humeral circumflex artery, posterior humeral circumflex artery. That's why it got the name as the circumflex nerve. The axillary nerve goes along with the posterior humeral circumflex artery, since it got the circumflex nerve. Okay, so that's the vascular complications. Next, what are the other signs we can see? Brighton sign. So there is another sign called the Brighton sign. B-R-Y-T-A-N-T, Brighton sign. So this another sign, the regiment Bard sign. What is called the Brighton sign? So in case of anterior dislocation, when you inspect the shoulder of the patient, imagine my anterior shoulder is went for an the left shoulder went for an anterior dislocation, and when I analyze my left shoulder, there is the Brighton sign is the lowering of the anterior axillary fold. This is the anterior axillary fold. So the lowering of the anterior axillary fold. Why there is a lowering? Imagine when the humerus can be used as a lever. If you lift the humerus, what happens? The axillary fold moves up, and if you bring the humerus down, the axillary fold is coming down. So this humerus acts as a pillar. It acts as a pillar so that these two folds, the anterior axillary fold as well as the posterior axillary fold, will be in a elevated position. Just imagine a tent. So there is in the middle there is a pole. If you elevate the pole, what happens? Both sides of the tent is elevated. Same like that, the humerus will elevate the axilla so that both the anterior as well as the posterior axillary fold is elevated. But in case of anterior dislocation of the shoulder, since the humerus moves inferiorly, head of the humerus moves inferiorly, there is a lowering of the anterior axillary fold. So that is called the Brighton sign, lowering of the anterior axillary fold. Okay. Next comes the Hamilton ruler test. What is a Hamilton ruler test? In a normal person, if you keep a ruler on the acromion process, and this ruler will not come in contact with the lateral epicondyle. Okay, in a normal person, if you keep a ruler on the acromion process, and this ruler will not come in contact with the lateral epicondyle of the humerus. This is because the head of the humerus as well as the deltoid muscle will form an anterior bulk so that the ruler will not come in line with the lateral epicondyle. But in case of anterior dislocation of the shoulder, the head of the humerus will move medially, anteriorly and inferiorly. So the convexity of the head of the humerus or the bulk you can see on the anterior lateral aspect of the shoulder joint is compromised, so that there is a flattening of the shoulder taking place, and this makes it possible for the acromion process as well as the lateral epicondyle of the humerus to comes in a straight line. So that is called the Hamilton ruler test positive. Hamilton ruler test. Hamilton ruler test positive. Hamilton ruler test positive. That is, the acromion process as well as the lateral epicondyle will come in a straight line. That is called the Hamilton ruler test. And the third test is called the Colway's test. CAL. It's written as Colway's, but it's Colway's test. So what is Colway's test? Colway's test is nothing but the vertical axial axial circumference is increased, the vertical. So when you take the circumference, the vertical circumference of the axilla, the vertical circumference of the axilla is increased. Why the vertical circumference of the axilla is increased? You understand? So if you take the circumference or the vertical circumference of the axilla, this will be increased. Why it is increased? This is because in case of anterior dislocation, the head of the humerus is moving inferiorly as well as anteriorly. So when you take the circumference of the axilla, the vertical circumference of the axilla, we have to cross the head of the humerus while taking the circumference, which automatically will increase the vertical circumference. So Colway's test is the increase in the vertical circumference of the humerus. And next test is called the Dugas test. D-U-G-A, Dugas. What do you mean by the Dugas test? So if my left shoulder is anteriorly dislocated, so if an examiner asks me to touch my opposite shoulder, touch the opposite shoulder and bring my elbow towards the chest, the patient can't do. Okay, so ask the patient to bring his affected shoulder or the dislocated shoulder towards the chest. At the same time, ask him to bring the affected hand over the unaffected shoulder. The patient cannot do the movement. So in case of left shoulder anterior dislocation, ask the patient to bring his hand on his right shoulder as well as bring his left elbow towards the chest, which the patient cannot perform due to anterior dislocation. And this the other test is the anterior apprehension test. So what is the anterior apprehension test? So when you ask the patient to go for an abduction as well as external rotation, the patient will apprehend the movement. Or if you passively try to do an abduction as well as external rotation, the patient will stop you from doing the movement. That is called the anterior apprehension test. Why it is called the anterior apprehension test is that the same test we are going for posterior dislocation. That's called anterior apprehension test, belongs to the anterior dislocation of the shoulder. So these are the basic signs and the basic test for anterior dislocation. The next, there are few other tests that is called the specialty test, which we are going to see when you are seeing the complications of anterior shoulder dislocations. Okay. So next, this video is going to be little longer video. So I thought I can finish the entire anterior dislocation in shoulder in one video, but it is almost half an hour. So if I again explain the anterior dislocation complication, it will take another half an hour more. So that I am going to explain in the next video. So in this video, let us see what all things. So I was talking about the anterior dislocation of the shoulder. What is the mechanism of injury in the anterior dislocation of the shoulder? Of all shoulder instability, and 95% of instability falls under the anterior dislocations. Okay. And we saw what are the mechanism of injury, what are the etiology for anterior dislocation, the traumatic and the non-traumatic causes, and we see what are the types of anterior dislocations and what is the position, what are the position of the shoulder. And of course, when there is an anterior dislocation, the patients will complain of the pain. The patient will complain of pain. there is a pain will be there. The head of the humerus can be seen anteriorly, medially and inferiorly. The shoulder is in the abducted and external rotator position. The head of the humerus can be felt anteriorly, and if you try to press on the anterior aspect of the shoulder, the patient will feel discomfort. And the acromion process can be seen posteriorly as well as laterally, and there is a neural as well as the vascular complications can arise. So what are the signs? The regiment bad signs, mainly there is a loss of sensation on the at the deltoid muscle. Okay, and you can see the Colway's test, where there is a vertical increase in the vertical circumference of the axilla, and there's a Dugas test where the inability of the patient to bring the hand on the opposite shoulder and bring the elbow towards the chest level. So all these things keep in your mind when you are looking for the test. So the next video is going to be the structural complication arises with the anterior dislocation of the shoulder. Mainly we are going to see the Vanguard's lesion as well as the Hill-Sachs lesion. Hope you guys understand. Thank you so much, and see you in the next video. Bye bye.